It's a pure prognostic marker. It's kind of been all over the place. There are studies in young fit patients that IDH2 has a good prognosis. It's been intermediate, by itself. I think where some interesting data came out of ASH were presentation by Dr. Paulier from University of Colorado, looking at outcomes of HMA venetoclax in the IDH population. And what was quite striking is the IDH2 mutant patient population specifically did the best. Actually, I don't even think they met a median overall survival with a quite mature follow-up. They basically took all the patients from the Viale trial and I think some of the earlier phase 1b/2 studies. So clearly, the IDH2 mutant group in particular does very great with HMA venetoclax. Even to the point that for, let's say, a patient over 60, would they be better served with HMA venetoclax over induction chemotherapy? I think is a critical question that we need to answer. The depth of remissions are great, and so maybe the outcomes post-transplant would be great. These are unanswered questions. I think where we're at in the field is whether or not triplet is the right strategy. So there are ongoing, triplet concepts either in development or active, where could you do aza, venetoclax, and axitinib, and will that move the field forward? So I think a lot of the big questions are more in the HMA venetoclax, setting. I think what IDH2 means in the setting of induction chemotherapy, and should molecularly targeted agents or venetoclax be added to IC chemo? I think those are questions that are being looked at, but maybe a little bit far behind. But I think very encouraging data in elderly AML with the combination of HMA venetoclax in that patient population.